Hi everyone, my name is Dr. Wade. I'm a neurology doctor who works at the National Hospital at UCL in London, and I work for the NHS England Leukodystrophy or Inherited White Matter Disease group. I've been working with the group for about 5 years, and last year I started a PhD in white matter disorders, which includes multiple sclerosis, but also includes inherited leukodystrophies. And I'm very grateful to have been given some time this morning to tell you about one leukodystrophy in particular, which is adult-onset leukoencephalopathy with axonal spheroids and pigmented glia, which is ALSP. And I'll tell you a bit about the background of the disease, and then I'll also tell you about 2 trials that Vigil, Neuro are undertaking. One is a natural history study of the disease, and the other is a first of its kind drug treatment for ALSP. So, adult-onset leukoencephalopathy with axonal spheroids and pigmented glia ALSP is as it sounds, an adult-onset inherited leukodystrophy, which encompasses 2 previously described terms, so POLD, which was described in the 30s, and HDLS, as you can see there, which was described in the 80s, and we now recognize that these are full part of the same disease, which is ALSP. And our genetic understanding actually has sort of further delineated these, and we now know that the most common cause of ALSP is via a CSF1R gene mutation, which probably makes up over 90% of the disease makeup. But there are other genes involved, AARS, so Rs, and then also Rs2, which we see in a much smaller patient population. ALSP is a white matter disorder that starts in the 30s to 40s, although obviously the range is much greater. We see patients as young as 18 and patients as old as 70 when they present. And it presents with a largely behavioral and cognitive change that can look very similar to a frontotemporal dementia-like phenotype. But there are accompanying motor symptoms, including pyramidal and extrapyramidal features, gait ataxia, and also seizures. And as the disease progresses, the patient can become incapacitated and have bulbar symptoms as well. So as you'll see on the slide here, we have some sort of examples of imaging, and it's a largely bilateral, symmetrical, but can be asymmetrical white matter involvement on this FLAIR image. It's a periventricular pattern, but with a frontal lobe predominance. And other features that we see early in the disease is sort of cortical atrophy, as you'll see here. Very specific corpus callosum thinning. On DWI, we see diffusion restriction in these sort of characteristic dot-like patterns, so diffusion dots. And then on the CT scan here, you can see these characteristic stepping stone-like appearances of calcification in the frontal horn. So lots of imaging hints to diagnosis, but obviously the diagnosis comes from confirmation of a gene mutation. It's an adult onset disease that is relentless in its progression and fatal. Mean duration to incapacitation, so disability is 3 to 4 years. And mean duration to death is only 6 years. Although we know a lot about the disease, we don't know enough about the stages and rates of change to the lab markers, the symptom markers, and including and the imaging markers as well. And we need this information really if we're going to be able to introduce drugs into this treatment so that we can know what impact the drugs are having. As I say, as a result of this, there are no approved therapies for ALSP at the moment, and we need to answer some of these questions before we can get those drugs into the market. So now I'd like to tell you about the natural history study, which Vigil have been running for the last 18 months or so. We have been running at the National since October of 2022. And we have 1 patient enrolled, which is very exciting. And we're always looking for more patients for this study. And as I referenced on the last slide, this study is really to answer those questions about what happens to the disease over a short period of time, so that we can have an idea of those clinical and imaging and blood biomarkers and what impact the drug has on those. So this is a little bit more about the disease, about the study. Who can participate? So anyone who's 18 years or older who has a confirmed genetic mutation and who also has symptomatic, so clinical or imaging changes that confirm the diagnosis. As you can see there, you can travel, well, you can attend from any of the 5 countries listed: America, Canada, Germany, Netherlands, and the UK. But it's important to realise that if you have patients who are affected outside of these countries, there is travel assistance and stipends available to get them to the nearest centre or the most appropriate centre for them. So we're not restricting it at all. So let's have a look at what the trial looks like. It's a 2-year commitment for patients, or just over 2 years, really. They come in for an eligibility and screening assessment, where we also do a biomarker and an MRI sample, and we do some clinical questionnaires and clinical exams. And then they attend every 6 months for a biomarker and MRI tests, and also those same clinical questionnaires and exams. And as you can see from this, it's an observational study, so there's no drug given in this study. It's just us collecting this data as best possible, really, not just for our understanding of the disease, and not just to sort of enable us to give patients better prognostication, but also so that we can know when we do introduce drugs what impact they have. So now I'd like to tell you about a phase 2 trial that Vigil are running of Vigil 101, an antibody TREM2 agonist. But before that, we need to go back and learn a little bit more about the science and the pathophysiology of the disease. So I'm afraid this is going back to med school for you. CSF1R, so the main gene involved in ALSP, CSF1R's colony stimulating factor 1 receptor, is a sensor or a tyrosine kinase receptor that sits primarily on microglia in the CNS. You can see you have a nice picture of a microglia here. And microglia are sort of specialized immune cells within the brain and the spine that are sentinel, that are involved in immune defense, that are involved in monitoring the environment and making sure it's a sort of healthy one for nerves and for myelin as well. And they're also involved in neural development. So, I mean, a few of the functions here listed here that you can see, but they sort of have a phagocytotic role, and they clear up debris. They're involved in survival and proliferation, making sure the environment is sensible, and they're involved in pruning of synapses, so sort of chopping the heads off the synapses that you no longer need, that were sort of made in excess, and making sure that the sort of healthy neuro environment is maintained. So we'll zoom in a little bit more on that microglia. So we've got our cell membrane here, so everything above it is extracellular outside the cell, and everything below it is intracellular in the cytoplasm. So this is the CSF1R receptor that I was talking about earlier. We know that this is damaged in ALSP. And what the CSF1R receptor does is it binds to extracellular proteins, so it binds to CSF1, but also an interleukin-34. And when that happens, it initiates phosphorylation of the intracellular domain, and via that pathway and via the DAP12 pathway, that activates SYK and SRC signaling pathways, which, as you can see from this slide, further downstream is involved in the functioning of the microglia, so that allows for the survival, proliferation, the phagocytosis, and the motility of the microglia. We know that if you have healthy CSF1R, you have healthy microglia, which can be involved in repair and maintenance and neuroprotection. But we also know that if you have dysfunctional microglia, that is the basis of the pathology of ALSP. If you have dysfunctional CSF1R, you'll have dysfunctional microglia. And that's when we start to see the characteristic changes on pathology slides, but also on imaging that we've seen. So as this image shows, there are also other sensors on the cell membrane. And it's important because these sensors, although they have different roles, they actually share common signaling pathways. So another sensor I'm going to tell you about today is this TREM2 sensor, which is here in blue. And TREM2 has a different role, so it's essentially only activated by damaged and debris, sort of coming off damaged cells. But when it's activated via the DAP12 pathway, it also activates SRC and SYK signaling pathways, which, as you can see, and as we saw on the previous slide, allows the microglia to function. So why this is important is that although they have different functions, they share a common signaling pathway, and Vigil, the Vigil 101 antibody, which is a TREM2 agonist, so it activates this signaling pathway, are using that to rescue the damaged CSF1R function. So although this pathway isn't working, the TREM2 pathway is now working if we activate it with the antibody. And then we get the same downstream signaling we would have had even if CSF1R was working. So the idea behind the drug is that we can sort of rescue the loss of function seen in CSF1R and sort of ameliorate the ALSP damage by activating a very common and shared pathway. So now I'll tell you a little bit about how that trial will look, and it's launching worldwide. You can see that the countries involved are very similar, and again, to remind you that you can travel from all over the world for this trial. There's travel stipends are available if you're interested in enrollment. Participation are very similar, so who can participate? Anyone who's 18 years or older, anyone who has a documented genetic diagnosis of CSF1R, and anyone who has clinical features of ALSP that is sort of in the mild to moderate range. So this is the sort of final slide just to tell you about the trial design. It's a year-long study. It's an open label study, so everyone will receive the drug. And after screening, patients will come in monthly for their infusions, and they'll be followed up for a year with analysis happening throughout. After that year, there is the opportunity for further extension on an open label basis, so patients would continue receiving the drug if it seemed to be beneficial. As you can see at the bottom, we have sort of variety of outcome assessments. It's a phase 2 trial, so primarily looking at safety and tolerability of Vigil 101 in the patient population. But we're also looking to see the impact that Vigil 101 has on the imaging markers that we looked at, so brain volume, white matter lesion volume, the biomarkers, so we can look at the impact it has on the sort of CSF and blood biomarkers. But we can also use the data that we collect in this trial to work out the pharmacokinetics of the drug. So making sure that we're giving patients the right dose at the right interval, making sure that it's tolerated, but also efficacious at those levels. So that's all I have to let you know today. And I hope that you take away a few things from this talk. I hope we've given you a better understanding of what ALSP is and the patient population that we see. I hope I've given you an understanding of the structure of the natural history study that Vigil are running and why it's important. And I hope I've also given you an idea about how TREM2 agonism via the Vigil 101 antibody is an important and sort of hopefully promising target to treat this patient population and be the first treatment of its kind for ALSP. So if you have any further questions, Andreas is going to be present to answer those tomorrow, but also please feel free to email this email here, patients@vigilneuro.com. And I thank you very much for your time.